Welcome to this special live program in the new iWorld Live studio. This gorgeous studio. I have a gorgeous guest today. This is Mark Kontos. I'm very excited to speak with you. There are, it was almost better in the era when presbyopia IOL correction was one choice, because then we didn't have to think about what the different
Absolutely.
options were. Now, not only is there more than one choice, but there's more than one technology, and each one brings different things to the table. And what I'm thinking about are EDOF lenses. EDOF lenses have not displaced genuine multifocal lenses. You did a study well, you know what? I don't have to describe the study. I have you here. Mark, what'd you do?
Well, Josh, thanks for having me. It's a pleasure to be here today. And yeah, we looked at, you're absolutely right. Things have become more complicated, and we're always trying to make our patients as happy as we possibly can, especially that group that has kind of gone the extra mile to spend some extra money and want a little bit of a different outcome than the standard cataract surgery. And I was seeing that when we were using EDOF lenses in bilaterally, we were sometimes having patients that just weren't seeing as well as they need to up close, and they had a little bit of dissatisfaction there. And I was wondering, well, is there something we can do about that? And so what I did is I did a study in our practice where we took two groups of patients, and one group was a bilateral EDOF lens, the Tecnis Symphony lens. We put that in both eyes. And the other group, and there were 11 of those patients, and then the other group was 14 patients where we put a Symphony lens in one eye, an EDOF lens in that eye. Then the other eye, we put a Tecnis multifocal 3.25 in. We looked at those patients 4 months later after everything had settled to see how they were doing. We wanted to see how their distance vision, intermediate, and near vision was. And then secondarily, how much were they needing glasses to read with, and how satisfied were they? And those were the things that we looked at, and we found some interesting things.
Now, I'm curious what those things are, but I want to sort of spell things out first. So this is absolutely definitively, positively not monovision. That's not what
No, absolutely not.
we're talking
Yeah.
about here. These are overlapping MTF curves. The different
Correct.
lenses have got different strengths in different places. Having said that, the multifocal lens that you put in has an MTF curve that has much more area under the near portion than
Correct.
obviously the EDOF lens does. I'm curious, and again, with my understanding that this is not monovision, did you choose to put that lens in the non-dominant eye?
Most of the time we did. Sometimes there were differences where we needed to look at some toric issues, issues with astigmatism, where we have toric ability with the Symphony lens and we don't in the 325. There were times when that played a role in the decision as to which eye that went. If that was not the case, then we put the Symphony lens in the dominant eye, and the 3.25 did go in the non-dominant eye.
Okay, so I'm dying to hear, what'd you find out?
Well, what we found was, as you kind of alluded to, both groups saw great in the distance. We had excellent distance acuity. There was really no difference there. They were doing very, very well there. In the intermediate range, we also found that both groups did, for the most part, equivalent. The bilateral Symphony group did slightly better in intermediate vision than the combination group. But where the real difference was in the near vision, and that's where things really changed. And in the bilateral EDOF group, we found that the amount of patients that were seeing 20/25 or better in that group was really only in around the 30% range, whereas in the combination group, we had 90% of our patients reading the 20/25 or better line bilaterally or binocularly in the near group. And so that was a significant difference there. And when we looked at overall satisfaction and reading glasses needs, as you can imagine, that kind of correlated with that. And so when we looked at the amount of time that patients were needing reading glasses in the bilateral Symphony group, those patients were using glasses either sometimes or all the time for reading material, almost 60% of the time. Whereas in the in the mixed group, we were seeing only about 12% of patients needed to use reading glasses really at all for anything in that group. So it was a much different scenario there. Then what was really important to me, because where the rubber meets the road for us as ophthalmologists is making our patients happy.
Yeah.
What was the overall satisfaction? And again, it paralleled that same thing. When we looked at the numbers, they were almost identical as we went across for the reading issues. So it turned out really that when a patient, in our mind, spends money, you have to be able to give them good reading vision in order to have them say, I'm very satisfied with what you've done for me. And that's really what this study showed. And that's, we saw that that level of satisfaction was very high in the combination group. The level of satisfaction was good in the other group, but we're striving to always make it as good as we possibly can. And that's where things really kind of differentiated for us. And that's why I came away from this, looking at this study, that these patients can actually do very well, be highly satisfied. 3/4 of our patients in the combination group said they were very satisfied with their outcome. And I think if you can get that level of satisfaction across presbyopia correction, that's pretty significant.
Yeah, no, and I love the way that you laid out your findings first in the objective findings, which always seem to me to be about surgeon satisfaction, not patient satisfaction, and then talking about the way that independence with near spectacles translated to patient satisfaction. Okay, great. Having learned this, have you changed your clinical practice pattern? And are there any patients for whom you don't do this, for who are not good candidates for this?
Well, and that's a great question, and it has changed the way I look at things. I do tend to really now default to a combination scenario. I want to kind of personalize the vision for the patient that's in front of me. But that doesn't mean that that's the answer for everybody. And because there are patients who get a bilateral EDOF lens that are thrilled with their results. And there are patients who will say, that intermediate vision is what's really most important to me. And if you satisfy them there, then they'll be very satisfied. Maybe the near isn't so critical for some individuals. And so in my mind, it's important, it kind of goes back to the age-old thing. You've got to sit down and talk to the patient, understand what their goals are, and then try and match those goals before the surgery itself. So there's going to always be this sort of idea of let's sort of match this to what your goals are, and we'll create a combination that works for that. And that may involve many different combinations of lenses. This was just one that we looked at.
So you've taken this optically complicated topic. You've made it very, very clear. I understand everything that you're saying, and it makes perfect sense. What's your chair time like? I mean, in your conversations with the patients, because this is something that's complicated for an ophthalmologist,
right,
let alone someone who comes in and says, "Doc, do what's best."
Yeah. Well, I try not to make it too complicated for the patient. I try and get a sense of what do they want. And then I try and really tell them, look, I'm going to try and use all the tools in my toolbox to try and give you what you're desiring here. And that may mean we're going to use a couple different types of technology here to satisfy you. I find that patients are very receptive to that. When you kind of give them it in those terms, then they're like, yeah, that sounds great. It's kind of like when you go buy a car, you like to maybe pick what the upholstery is going to be or what the color is going to be or this, that, or the other. People are used to personalizing, their choices in life. And if you can kind of go into it in that mode, like let's talk about what works best for you, people are very receptive to that. I try not to get into too much of okay, this lens does this and this lens does that, or this one has this technology, this has that. Patients don't really, that's not something that's really germane to what they want to know. What they really want to know is that, okay, what's my outcome going to be? How am I going to see? How are things going to work for me? And that's really what we try and focus on with this. So it doesn't really, once you get the gist of it, and once you get your kind of way of describing things down, to be perfectly honest with you, the chair time is not that much, and it saves me a lot of chair time on the opposite side.
Yeah,
in
well,
the
of
post-op
course.
area.
Yeah.
That's where you save your money, where you save your time and money is on that side. If you can deliver, the kind of result a patient wants, boy, your chair time afterwards, all they're telling you is how great things are, and that chair time I love.
Yeah, no kidding. This is really, really great. I'm glad. First of all, I'm glad that you did the study. Because this is really clinically relevant info that you're passing on to us. And I'm glad that you've made it clear, and I'm especially grateful for the generosity of your time.
Thank you.
And I'm grateful to you for watching this special live presentation. I'm not going to ask you whether it's worth your time, because I know that it was worth my time. I want to thank you very much. I want to thank you, and remember, tell your friends about iWorld Live.